Well, thank you for joining. I'm Ron Petersen, professor of neurology and the Cora Kanow professor of Alzheimer's disease research at the Mayo Clinic in Rochester, Minnesota. Welcome to this social media event supported by an independent educational grant from Eli Lilly. Joining me today are Sharon Cohen, behavioral neurologist and medical director at the Toronto Memory Program in Toronto, Canada, and Henrik Zetterberg, professor of neurochemistry at the University of Gothenburg in Mölndal, Sweden. Welcome to both of you.
Thank you.
In this half hour, we will discuss the importance of timely and accurate diagnosis in the early stages of Alzheimer's disease. We'll be looking at the types of AD biomarkers that are available for clinical use and what are the benefits of measuring AD biomarkers in clinical practice. We'll close with some key takeaway comments. We'll be taking a bird's eye view here, just a big picture, 10,000-foot look at as an introduction to a more detailed CME programming that will be featured in year 4 of Medscape's clinical advances in Alzheimer's disease. And as you can tell from the three of us, we're going to present different viewpoints. That is, while I'm not totally representative of all of the United States, I'm from the United States. Sharon is from Canada, and Henrik is from Sweden, representing Europe. So we'll have different perspectives on how these biomarkers are being used in the diagnostic process. So, one of the first questions that comes up is why is a timely and accurate diagnosis of early stage Alzheimer's disease important? Well, I think many patients come into our offices with a memory complaint later in life and they're saying, gee, is this Alzheimer's disease or is this something else? And it's sort of incumbent upon us then to sort this out and try to figure out, is this memory problem a part of normal aging or is this more worrisome that may be the earliest stages of Alzheimer's disease? Because if we make the diagnosis of Alzheimer's disease, one, where do we go from here? Might help the patient family plan as to where they are down the road. But more recently, of course, since there are disease modifying therapies available in some countries for Alzheimer's disease, people may very well want to know, am I eligible? Am I a candidate for these drugs? Might these drugs be appropriate for me? So that certainly is a new question that's come up in the last couple of years. Well, when we make the diagnosis of Alzheimer's disease these days, we certainly want to be aware of what we're talking about. That is the terminology of Alzheimer's disease itself. So, over the years, certainly, the diagnosis of Alzheimer's disease has evolved from a clinical pathologic entity to a biologic entity. And by that, I mean, certainly when I started practice, we would take a clinical history, do an examination, and do a bunch of rule out stuff. And if we didn't find another cause for the cognitive impairment, we would say this is probable Alzheimer's disease. And by that, we meant that we couldn't say it was definite Alzheimer's disease until the person passed away, had an autopsy. We looked at the brain under the microscope, saw plaques and tangles. These days, I think with biomarkers now, we can be much more definitive in life as to what the person may have with respect to an underlying cause of the problem. I'm sort of old school, so I go back to the days where we make the clinical diagnosis of the syndrome first and then ask the question about the underlying etiology. So, through our clinical exam, we try to determine, is this in fact cognitively unimpaired, normal aging? Is this possibly subjective cognitive decline? Is it mild cognitive impairment or is it dementia, mild, moderate, severe dementia? After we make that clinical assessment, then we say, okay, now what's causing it? And here's where the biomarkers come into play. Certainly over the years, as clinicians, we've been pretty accurate at when we say it's likely Alzheimer's disease, but there's a significant proportion of the time where we're wrong. It's not Alzheimer's disease, or Alzheimer's disease is only part of the picture. Consequently, these diagnostic accuracies have been problematic in the development of therapies for Alzheimer's disease. So, from the clinical pathologic days in the mid 1980s till the teens, at least, we dealt with the clinical pathologic correlation. However, in 2018, committees were formed that looked at the diagnostic landscape and came to the conclusion, maybe we know a lot more about the disease now in life from a biologic perspective, and they proposed that Alzheimer's disease be diagnosed biologically by the presence of amyloid and tau using biomarkers. That was a shakeup in the field. Clinical impression was still important, but the disease was diagnosed biologically. Fast forward 2024, the committees then revised the criteria. They kept the basic premise that we're talking about a biologic entity, the presence of amyloid and tau, but now with new biomarkers on the scene, in particular fluid biomarkers, we could be much more precise perhaps and more available to a broader audience with, for example, blood-based biomarkers. So the field has evolved now to where the clinical syndrome is still very important, but the diagnosis of Alzheimer's disease is made biologically. But I should point out that in the 2024 revision, there was one aspect of the criteria that sometimes is misinterpreted, and that is one of the core 1 biomarkers, which would be adequate for making the diagnosis of Alzheimer's disease, was an amyloid PET scan. So if the amyloid PET scan is positive, the person qualifies for the biologic diagnosis of Alzheimer's disease. So, by that, do you mean that if the person is just amyloid positive, they have Alzheimer's disease? And that's not quite the case. In fact, because what the authors of that proposal contend is that if a person has a positive amyloid PET scan, they're symptomatic, they have a 95% chance of having both amyloid and tau present in their brain. So, in that sense, they haven't deviated from the biologic definition. Rather, they've expanded it to some of the new biomarkers that are available. But that's what we want to talk about today to really get a feel for how good are these biomarkers. So, Henrik, let me turn to you now. Can you kind of give us a encapsulation of where the field is with regard to the biomarkers for Alzheimer's disease?
Yes, thank you, Ron. And it's a very pleasure to be here also. We have gone now from having amyloid PET and cerebrospinal fluid tests that have been well validated in regards to neuropathology. And now, during the past 5 years, we have started to see that many of the CSF biomarkers are actually possible to measure in blood. And the biomarker that has had the best success in blood is phosphorylated tau. And it now turns out, if we look at the aggregated literature accumulated over years, the last few years, tau phosphorylated at amino acid 217 seems to be a really good biomarker for Alzheimer's disease. There are a number of assays that measure this biomarker accurately and with high sensitivity, and there are some studies indicating equivalence to CSF. We also see how the biomarker changed during the course of the disease. So when amyloid starts to accumulate in the brain, according to PET studies, then you have a little bit of an increase in plasma phospho-tau levels. And when the disease progresses over the brain parenchyma, the phospho-tau levels increase progressively. And in the symptomatic stage of Alzheimer's disease, plasma phospho-tau correlates quite well with the amount of Alzheimer's pathophysiology measured using tau PET. So phospho-tau seems to react to amyloid, but also track or predict tangle pathology progression over the brain. And the higher the levels, the more pathology in the brain, it seems.
Very good. Thanks, Henrik. Well, I think with that as a backdrop then, Sharon, how do you use these clinically? Do you incorporate the biomarkers, blood-based biomarkers and others into your practice at present?
I very much like to, Ron, when we can. And some of the constraints that we have are availability, patient acceptance, cost. However, it is wonderful that we're in a time now where there are options for patients. I'm practicing in Canada, and patients do want to know what's wrong. Is this Alzheimer's that's causing my memory problem or something else? And we should want to know also, because if it's not Alzheimer's, we should look a little bit harder for another cause. When it comes to PET imaging throughout Canada, we have uneven cost coverage. Mostly we don't have public funding yet, but we do have an amyloid tracer fully approved for clinical use, and for those who can afford it, that is a good option. As a clinician, I actually like CSF because I get more information. We can do the spinal tap in our own office, which we do readily, and we get not just an amyloid measure and not just quantitative results, but also we can get various p-tau isoforms and other markers, whether it's of neuroinflammation or neurodegeneration. So for one CSF sample, you get a whole lot of information, plus you get the quantitative values. Whereas with PET amyloid read, you get positive or negative. And I and my patients are both saying to each other, well, how positive, how negative? This isn't quite as gratifying. There will be some people who can't tolerate an LP, perhaps because they can't come off anticoagulants or they have spinal deformities. But in our practice, we found that most individuals are able and willing to have an LP. Now, with plasma biomarkers, this is just starting to be available in Canada. There are a few different assays, including mass spec and immunoassays. And there is variability in terms of clinician readiness to say, this is enough, this is a diagnostic test, or this is a pre-screener, and then we go on to a diagnostic test. So maybe that's something we all want to give some input into. How accurate do you have to be? And would 2 cut points help? So you have clearly positive, clearly negative people, and then an intermediate zone where you would go on to another confirmatory test, PET or CSF. So the field's moving forward, but there's no question that a blood test is more acceptable to patients and clinicians. It fits more readily into practice, clinical practice, and individuals, whether you're in an urban center or a rural center, can have equal access. You don't have to travel to a university town to have your PET scan or find a physician who will do an LP. So, and potentially cost savings to our healthcare system and patients as well with blood-based biomarkers. So it's a very exciting time, and I think I'll leave it at that.
Sure. Thanks very much. So Henrik, Sharon mentioned the sort of positive, negative, and intermediate zone. You and your team in Sweden have sort of championed that. We've done a little bit of that work here at the Mayo Clinic as well. Do you see that as being a way to move forward with blood tests, or do you see a sharp demarcation? I think some of the mass spec tests say positive, negative, period. Which way do you lean?
I think at the moment we should go with this 2 cut point approach. And then what we have done in Gothenburg is that we can see that we have a reference limit in clinical chemistry that is defined as 95% of the amyloid negative people, if we talk about Alzheimer's biomarkers. But that will give there will be a little bit of an uncertainty around that cut point because of analytical variation and also some biological variation. If we use this 2 cut point approach, it seems like we will not have to do cerebrospinal fluid analysis or amyloid PET as often as we have done before. So we would. It looks like one can be completely satisfied with a blood test that is above the upper cut point, and then claim that this is a very high likelihood of Alzheimer's pathophysiology. If you want to start a treatment on the basis of such a result, that is a little bit up in the air at the moment. I think most clinicians would want to have a confirmation of the amyloid positivity at this stage. Below the lower cut point, you can be very certain there is no Alzheimer's pathophysiology. And the gray zone, you can handle that in different ways. If there is no rush, you could actually do like this, that you ask the patient to come back for a reevaluation 6 to 12 months later, and then you will see if the patient moves upwards closer to the upper cut point or even above it, or if the patient actually stays in the gray zone or even turns normal. So that is one approach. The other approach is, of course, to go directly towards a more precise test, amyloid PET or a CSF analysis. And I think it depends a little bit on where you work, what you would do in that case, in the case of a gray zone result. There is also, Sharon mentioned this possibility of getting patterns in CSF. This is emerging now also in blood. So we already now have reliable tests for neurofilament light, for example. So if you have in your practice the possibility of measuring both neurofilament light and phospho-tau217 in a blood sample, you will be able to use phospho-tau217 to capture Alzheimer's pathophysiology and neurofilament light to capture non-Alzheimer's neurodegenerative disease. I'm thinking a little bit about people who are in their 60s, where the prevalence of frontotemporal dementia might be a little bit higher. That is very much, their neurofilament light works quite well to catch that type of neurodegeneration. So, and then one could ask, should one also do an amyloid test in plasma? But there the jury is a little bit out. Some researchers think that is possible. We have been a little bit worried about peripheral beta amyloid obscuring the biomarker signal in blood compared to what we see in cerebrospinal fluid. And I think it's pretty fair to say also that phospho-tau captures to some extent also amyloid pathology, since it looks like the phospho-tau increase in biofluids reflect a neuronal reaction to amyloid to the largest extent, because many other tauopathies are negative. Actually, almost all other primary tauopathies are negative in regards to plasma phospho-tau and also CSF phospho-tau. So it looks like phospho-tau captures Alzheimer's tau pathophysiology in a manner that sort of gives information on both amyloid and tau.
Some of the multiplex panels also offer GFAP. You ever thought of GFAP versus NFL as a measure of progression?
Yeah, I think GFAP is difficult to interpret. When I work in clinical chemistry practice, it's very hard to tell why GFAP is increased. It is quite sensitive to amyloid pathology, which was a little bit of a surprise to us. But and this could be that. Well, initially we actually hoped that perhaps it captures or reflects cerebral amyloid angiopathy, since we have the astrocytic end feet in the neurovascular unit, and that could give a very clear release of GFAP, which then is an astrocytic marker, I should mention that, into the bloodstream. But that doesn't seem to be the case completely. So if one does GFAP, it's good to remember that it's not an Alzheimer's specific biomarker. Oh. There is one disease, Alexander disease, where GFAP is almost diagnostic because it gets very, very high. But that's a rare disease and not a differential diagnosis. Sure. So it's an interesting molecule, but I don't think it hasn't found its place completely yet.
Right.
And maybe in the future, when we have drugs targeting the immune system in Alzheimer's disease, then it will become important, in terms of monitoring treatment. But it is very intriguing, that we do see the impact of GFAP in the untreated patient with Alzheimer's. And also we have seen, for example, with the lecanemab phase 3 data, that GFAP somewhat normalizes with an anti-amyloid treatment. But perhaps its place is still to come with other therapies.
Yeah, that's an important comment. And I also think that there could be one potential of GFAP to monitor side effects, but there are no clear data yet there either.
Right.
So, Sharon, in your comments, it sounds like you're a CSF person for a variety of reasons. What do you think about using CSF1 diagnostically? It's pretty good. But what do you think about following therapies longitudinally? Do we know anything about the role of CSF in treated patients with amyloid modification drugs?
Well, we have seen data from anti-amyloid monoclonal therapy programs showing that with CSF, for example, p-tau181 and p-tau217, depending on which drug treatment program we're talking about, normalization, when you're targeting amyloid, you are also having this downstream impact on tau, not reverting these tau isoforms to completely normal, but sending them in the right direction. So is this enough to say your therapy is working? Is it enough to say you've cleared enough amyloid or you've impacted tau downstream enough to stop? In my mind, no, these can't be used yet as stopping milestones. But we are learning all the time, and maybe there will be a point where we say, okay, we've done all we can with this particular therapy, and now we go either to maintenance therapy or to some other approach. But I do like, as you say, the option of having multiple biomarkers in one specimen. And another thing about CSF, and perhaps with plasma, is we are not measuring plaque-bound pathology, static pathology that's built up over years. We are measuring something more dynamic and possibly earlier in the pathophysiology, particularly with CSF. I think CSF, from a diagnostic standpoint, becomes abnormal a little sooner than PET. So again, sort of leans me towards that modality.
So for our viewers, I think that's an important point. So maybe I'll ask both of you, what is the temporal sequence? If you have plasma, you have CSF, and you have PET, which one rolls out the first, and what's the sequence? Henrik, what do you think about that?
Yeah, data are, I think data relatively convincingly shows that the first sign of amyloid buildup in the brain is a plasma A beta change, but it's research and it's very subtle.
Right.
So it looks like clearance when amyloid starts to get a clearance problem, then you see it the earliest in blood, then you see it in CSF as a reduction in the A beta 42/40 ratio, and then you have A beta PET positivity. They are quite strongly linked, but anyhow. Soon after, you also get the phospho-tau increase, and then neurofilament light, tau, the synaptic markers, they come later, more in relation to tau PET, the tau PET signal. I agree completely with what Sharon said, that we have tissue biomarkers in terms of PET, the PET markers, and then the fluid-based biomarkers reflect more what is happening at the moment when you take the sample. And this has to do with production and clearance rates of these proteins.
Sharon, do you agree with that temporal sequence?
I do. I love it. I think Henry explained it very well, better than I could. And also, what are the implications for treatment, not just the earliest biologic diagnosis we can make, but looking at clearance. If we are just relying, for example, on clearing amyloid as determined by a PET scan, there's still lots of amyloid. There's soluble species, maybe the more toxic species, protofibrils, oligomers. So again, I lean towards fluid biomarkers to give me that. And some of my colleagues will say, well, don't you like to see regional anatomy in the brain? And of course, I'm a neurologist, brain behavior relationships. Yeah, I grew up on that, but I can forgo that because I'm getting something more.
You like to look at the organ of interest. You're a neurologist, so that's the appropriate thing. Well, that is interesting, but it does raise the question then of which of these biomarkers might be best to follow longitudinally with treatment. So I think we've established that these are very useful for the early diagnosis of the biologic aspect of Alzheimer's disease. Now we intervene with an anti-amyloid therapy. So what do we follow 12 months, 18 months down the road? Would you again lean toward fluid biomarkers, or would you go in the direction of show me a PET image to see if, in fact, I've reduced the amount of amyloid in the brain? Henrik, where are you on that?
Yeah, if I think about the research trials we are doing, I always encourage multimodality, basically, to do both PET and fluid-based biomarkers, and also collect CSF, of course. And all this, of course, is expensive and so, but it has taught us a lot. We have learned so much on fluid biomarkers by comparing them to amyloid PET and tau PET, and vice versa to some extent. In the clinic, I think we need to be much more pragmatic, and we will learn that most patients turn amyloid negative for the most potent anti-amyloid drugs within 18 to 24 months. But unfortunately, we don't have a fluid biomarker telling us when that is happening. And actually, the phospho-tau results in plasma, they are really encouraging and pretty amazing. I think you attack amyloid and you get the phospho-tau reduction, amazing. But if you look at how much this reduction is, if we think that in the symptomatic stage, then amyloid pathology gives you a 2 to 5-fold increase of plasma phospho-tau. The treatments reduce phospho-tau in plasma by around 30%. So it's not a complete normalization. And either this reflects what Sharon alluded to, that there could be amyloid pathology left, which the PET camera doesn't see, and then we still have an amyloid-related phospho-tau increase. The more daunting explanation is that there is an amyloid-triggered but amyloid-independent increase in phospho-tau, and that you have sort of amyloid-independent tau pathophysiology going on. And I think that we don't know this yet, and we have to be humble and we have to continue to study it. But I also think that we might now, in clinical practice, given that these biomarkers are available, at least getting increasing availability, we will learn this in clinical practice. What happens with plasma phospho-tau when you have treated 2 years and 2.5 years or 3 years with these anti-amyloid antibodies?
Sharon, is that your hope for the use of these fluid biomarkers in tracking therapy?
Sure, I do hope that we can use plasma biomarkers for this. But just to get back to your original question on this topic, Ron, I do feel a little bit differently in the sense that it depends on the treatment. It depends on the intervention. If your intervention is very specifically to clear plaque, then you want to monitor perhaps with amyloid PET. If you are targeting oligomers or protofibrils, then you're not seeing the whole effect of your intervention just by looking at an amyloid PET scan. So I think we have to be a little more eloquent and match the monitoring to the target of the intervention.
Right. We've just got a couple of minutes left. I think this is an exciting time. I think the revelation of these new fluid biomarkers is very exciting for us. Let's give everybody just a wrap up. Henrik, give me 30, 60 seconds on where the field is with the use of these biomarkers.
Yep, what's happening now in clinical chemistry practice is that we have several tests to measure phospho-tau markers in blood. These tests are very accurate. They work on general clinical chemistry instruments, the workhorses of the normal clinical chemistry labs that many of us have nearby in our clinics. So I think we will see an upscale of the availability of these tests. And they are pretty good, actually. I'm very hopeful that this is that this will turn out to be widely used tests to help primary care physicians to diagnose Alzheimer's disease and speed up the detection of early symptomatic patients who should be rapidly evaluated for start on disease-modifying treatments.
Very good. Sharon?
Yeah, I would just add that early and accurate diagnosis do matter. They matter to patients. They matter for many reasons, not least you don't want to miss a treatment window for a patient who's early in the disease because you didn't capture and characterize this disease adequately soon enough. And now we have the ability to do that. So it's up to us to ensure that we bring these biomarkers to clinical practice in a sensible way.
Great. Thanks very much. I want to wrap up by saying that Medscape Education is kicking off year 4 of its clinical advances in Alzheimer's disease, preparing for the future. This is supported by an independent educational grant from Eli Lilly and includes CME programming, focusing on the diagnosis, biomarkers, therapeutics, and also neuroradiology. For the diagnosis track, one goal is to promote the integration of biomarker testing in the diagnosis of early stage Alzheimer's disease. This programming includes a series where we will hear stories from clinicians who are already incorporating biomarker testing into the diagnosis, and a series on how to communicate with patients and families about the use of biomarker testing. So, Sharon, Henrik, thank you very much for this discussion. And I want to thank you for joining us today. Stay tuned for more programming from Medscape Education, and be sure to scan the QR code or click on the link that is shown to receive credit for this discussion. So, once again, thank you very much.